Hello everyone, welcome to the next seminar in the Te Puna Haumaru seminar series. It's my pleasure today to introduce three speakers. We're spoilt for choice. So we have Professor Rod Jackson, Sgt Brian Williamson and Dr Lisa Tompson. So before they start off, I'm just going to tell you a little bit about who it is that's speaking us today, about the lessons for evidence-based policing from the journey of implementing evidence-based medicine in New Zealand. So Professor Rod Jackson is a professor of epidemiology at the University of Auckland. He trained in medicine and completed his PhD in epidemiology at Auckland. His specialty interest is heart disease, and he's taught courses in epidemiology and in evidence-based medicine for around 30 years and has about 40 years of research experience in cardiovascular disease epidemiology. Sgt Brian Williamson has been at New Zealand Police for 25 years and has worked in many different work groups, including the frontline response, as a detective at CIB, before moving into leadership roles in District Intelligence and the National Intelligence Centre. Currently, Brian is a network lead at the Evidence-Based Policing Centre, and he's worked in different leadership courses, he's taken different leadership courses at Cambridge University and is currently doing postgraduate study in crime science at the University of Waikato. And finally, we have Dr Lisa Tompson, who is a senior lecturer at Te Puna Haumaru here at the University of Waikato. Lisa holds a PhD in crime science from University College London, and she began working in the evidence-based policing area in 2013 when she led one of the work streams for a large-scale research project to systematically assemble, appraise and translate the crime reduction evidence base for the UK College of Policing's What Works toolkit. Since her move to New Zealand in 2021, Lisa has worked with New Zealand Police to further their agenda to integrate problem-oriented and evidence-based policing. So I think you'll all agree we have a great lineup of speakers today, and it's my pleasure now to hand over to Brian to set the scene. Can't wait to hear what you have to say.
Thanks, Aotearoa, and kia ora koutou. Nice to see you all there. Look, I just want to set the scene by starting with what evidence is in terms of policing. We often refer to that as forensic evidence, but evidence-based policing is about research evidence, and so that's what we're talking about today, is the use of research into policing. New Zealand, we set up a evidence-based policing centre in 2017, December 2017, with our strategic partners, University of Waikato being one of them. ESR and Vodafone New Zealand, or now called One New Zealand. And evidence-based policing is all about what works in policing, and obviously, importantly as well, is what doesn't and what looks promising. It's not to replace police experience, because we have a lot of experience within police, practitioner level experience, but it really is to complement our decision making. Drawing on the breadth of objective knowledge and research allows people and leaders to make better quality decisions that infuse that research evidence into police experience. So just wanted to make that clear, that it enhances policing experience. Likewise with medicine, with clinicians as well. Our New Zealand Police Prevention First strategy comes alive when we apply crime science to it, with robust problem-solving models and to identify credible ways of reducing crime and harm. In 1998, Professor Larry Sherman wrote a landmark report on evidence-based policing, first introducing that term, they're calling that term of evidence-based policing, concluding that policing should follow medicine in becoming evidence-based. And that's really why we're here today, is to listen to Rod's journey of bringing that to New Zealand in the medical field, and it's a really interesting journey. So thank you, Rod, for your time and your expertise, and we're really looking forward to talking with you today. So I guess our first question is, what was the impetus for introducing evidence-based medicine to New Zealand, and how did it change practice?
Right. Well, firstly, thanks very much for inviting me along. It's a pleasure to be here. Even though I've been involved in evidence-based medicine, I've always thought about evidence-based everything. You can bring evidence to so many different areas. So it was it was great to hear about evidence-based policing. And I'm going to make a comment right off. One of the first things you said, Brian, was that evidence-based policing, you said we've got forensic evidence and we've got experience, and evidence-based policing was about the research evidence. But you then later actually, I was going to stop you there and say, actually, it's more than that. But you did actually come back and say it. Evidence-based whatever takes the evidence that you've always used, and in your case, forensic evidence. It takes the experience that you all have from doing your jobs for often decades, and it adds the research evidence. It doesn't downgrade any of the other the forensic evidence or the experience. It actually adds value. It adds another dimension, and I think that's important. And certainly, and the reason I raise it right from the beginning is that some of the early advocates of evidence-based medicine, I think, overdid. They really pushed, the research evidence and pushed that it was all about the research evidence, but actually it's not. It's about adding value to what you were doing before. Yeah. So it's the integration, and I think Lisa's going to show a slide later that we'll come to that. But in terms of the impetus, evidence-based medicine was a term first coined in the 1980s. There's a bit of an argument about who actually came up with the term and whether it was in the late 1970s or early 1980s, but actually not that long ago in terms of, if you think of disciplines in medicine, it's a very young, it's a very young discipline. But once people started talking about it in the 80s, everyone started reading about it. Like, people in journals, in a lot of educational material, as it was sort of getting a foot in the literature across the world in medicine. People started saying, what the heck is this? And of course, the first thing was, well, if people were saying, well, you need to practice evidence-based medicine, there was a bit of a challenge, because does that mean that what you're doing now is not evidence-based? And so, it did create quite a lot of heat as well as light. But so the first impetus was people started talking about it. And so colleagues of mine and others were wanting to, asking questions. So that was number one. Number two, and I don't know what it's like in policing, but certainly in medicine, there has been an absolute explosion of research evidence, and particularly the sort of evidence that I'm involved in, what we call quantitative evidence from randomized controlled trials, and databases, like big database type evidence. And that kind of evidence has exploded. In fact, it's an epidemic, speaking as an epidemiologist. And, I was looking at a slide, and this is from a few years ago, in the biomedical literature, so in the literature that people like me look at, there's over 5,000 articles published every day. Every day, 5,000. Randomized controlled trials, there's between 75 and 100 published every day.
Wow.
So, and this is 10 to 100 times more studies per day, somewhere between 10, and it varies from what it was in the 1980s. So back in the 1970s, 1980s, evidence was dribbling out. You didn't actually really need to have expertise in evidence-based medicine, given that evidence-based medicine is adding this research evidence, because there wasn't very much of it. I went right through medical school without reading an original scientific article. We read textbooks back then. So I'm old. I I was at medical school in the 1970s, but I went right through medical school without reading a single paper in the literature, because all the evidence that I needed was in textbooks. And the textbooks today, we don't use textbooks anymore in medicine because they're out of date before they're published. It's all based, but there was the sea change in how much evidence there was. So that was another huge pressure, is that it was being bombarded with evidence, and how did you make sense of it? And then the third thing, and I think this is absolutely key. When people started talking about evidence-based medicine, and people asked, what is it? And like I said before, it's actually integrating that research evidence with, in our case, our equivalent of forensic evidence might be a lot of the like anatomy and physiology and biochemistry, some of those more sort of bench sciences, which we've had that evidence for a long time, integrating that and also the personal experience. And when we said that, evidence-based medicine requires you to integrate those, we challenged people to be explicit. So we were really challenging people to be far more explicit about what evidence they were using, how much of it was evidence from this part, how much of it's from there, how much was it your own experience. And it was like, tell me how you integrate those.
Rod, would it be a good time to show your lovely X diagram at this point? Let me see if I can do that. Hang on. I think the audience should be seeing this. So do you want to talk through how you created this, or what it's supposed to kind of show? Yeah.
So this whole issue of the need to integrate different types of evidence, and I created this in many ways to actually take some of the heat out of the discussion about what evidence-based medicine was. Because as I said earlier, some of the early advocates of evidence-based medicine were only focusing on that top quadrant, the research evidence, and not only just on that top quadrant, but also on a particular type of evidence. And this is the quantitative evidence from randomized controlled trials and big data, the big data-driven evidence. But I created this to actually say, no, that's part of it. That's part of it. But of course, in medicine, what's absolutely key is the patient in front of you and their clinical circumstances. And because the research evidence may not be directly applicable to your patient. Actually, research evidence is seldom perfectly applicable to any specific patient. So what you really need to do is to integrate the best parts of that research evidence with what you already know about the patient. And also there are all sorts of other factors that come in the health system. It's, can you afford to do what you'd like to do? Are there legal issues? Are there legal issues about what is possible, the kind of interventions, the kind of diagnostic tests? Is it even possible? That's all the health system features. And then values and preferences. Nothing is value free. And so not only the patient's values, but also the practitioner's values. So I put this together to actually say, we're not actually trying to denigrate or reduce the importance of all of those things that you've been doing up to date to make decisions. We just want to make it better. We want to add value to that decision, those decision makers, by adding this research evidence. You'll also see that at the arrows at the top of the cross where they go up. In some circumstances, it's all about the evidence, and it's almost black and white. But that's seldom the case. In other circumstances, the patient's clinical circumstance are so overwhelmingly, they're just about to die or whatever, and there's really only one thing. So they're choking to death. Well, what do? You actually try to unblock that, some obstruction. So sometimes you don't even need to look at the evidence or even worry about values, preferences, and health system. You just do it. So these are quite flexible. And the reason I wanted to show this is because I think it's
it's beautifully parallel to a lot of the way police leaders and decision makers talk to me about how they can and can't use evidence, because a lot of the time they might just say, oh, well, it's all very well that it seemed to work over there in the US, but actually in my context, my community won't respond the same way. They've got, I've got real constraints over what I can spend in terms of staff time, in terms of other kind of resources. And actually, the context here is very different. So I think it's that real blend and learning when to lean into different parts of that quadrant, depending on the circumstances and the problem that's presenting itself.
Yeah, I agree. And, I think this picture has helped get people on the same page. So, because you're absolutely right in that in the discussion with police leaders, if you put something like this up, it gives them the license to talk about these other issues. It gives a framework, and I call this the X factor, and the expertise factor. And it's, people, certainly in medicine, I'm sure it's the same in policing, you talk about the art. We talk about the art of medicine and the science of medicine. Well, there's a lot of science in here, but the art is putting it all together. The art
for sure.
And the expert clinician, as indeed I'm sure the expert police professional is the person or people who are good at putting all these together and integrating them, but actually being explicit about it. And because I'm a teacher, these frameworks also help a lot, because by having a framework, I can go around each of these quadrants and I can be explicit as a teacher, but then decision makers can be explicit with each other and with their patients. About how we need to come to this decision.
Yeah, awesome. Yeah, thanks, Rod. Yeah, that's exactly what we say as well. It enhances your decision making. You're drawing on that breadth of knowledge and accumulated wisdom to enhance your decision making rather than just your own experience. So yeah, 100%. Yeah. The advantages of evidence-based approach you've found in New Zealand.
So you say the advantages of it?
Yeah.
Well, I think the advantages of it is have to do with where can I start? There's lots of advantages, but maybe the best place to start is, and my guess is it's very much the same in policing. If you look around a country or across the world, you will find huge variation in practice. We see huge variation in practice, and everyone has a reason why their patients are different. Their setting is different, and I guess this also comes back to what I was just talking about before. If you put decision making into these four quadrants and say, explain to me, around a particular problem, explain to me why you make certain decisions. Why is the way that you treat your patients different from the way, say, practitioners in general in Christchurch versus Auckland versus Wellington or whatever? And by using this framework, it gives everyone the license and the opportunity to explain why they make their decisions. And that has helped us in New Zealand get on the same page with a lot of different conditions. Like I work mainly in the heart disease field and in preventing heart disease by, and I've been very involved in developing national evidence-based guidelines about who should get cholesterol-lowering drugs, who should get blood pressure-lowering drugs. How do you treat different patient groups? And we've used this framework to help us get everyone on the same page. So I guess I would say that's probably the most important. I mean, that's one of the most important things about what we've done in New Zealand is so that we're all talking the same language.
Yeah. Cool.
How long did it take to see a real transformation in medicine becoming evidence-based in New Zealand?
Look, it's an ongoing process. It is absolutely ongoing, and it never stops, and it's changing all the time. But I would say that from the early 80s, I would say it took in the order of 20 years for it to become kind of common, sort of commonly accepted, and I think we had to get over that heat of it's all about this evidence, and experienced clinicians pushing back and saying, who actually felt, I think, threatened and defensive because they felt they were being criticised.
And infantilized in some ways, because it kind of, really just rode roughshod over their experience and the wisdom they'd accumulated.
That was some of the early advocates really, I think possibly did more harm than good. Because, there were definitely important gaps in decision making. But I think initially we went too far. And so I've been a huge advocate of saying this adds value to what you did before. I remember actually leading a course on evidence-based medicine, of all places, in Iran about 10 or 15 years ago. And this very wise old physician said, I was teaching this course, and he said, well, this is the first course in evidence-based medicine I've been to. Does that mean that, right through my career, I've been practicing bad medicine? It was a challenge. But, I had an easy response, and the easy response is he'd been retired for about 10 or 15 years, but he wanted to come and hear about the course. I said, during most of your practicing life, there wasn't that evidence base to add. But there is now this epidemic of evidence that means that we've got the opportunity to add it. So I don't know about in policing, is that also the same, that there's more and more?
Definitely, yeah.
But we're certainly going from a much lower baseline, and we have far less funding in terms of, like, globally, funding for research in the policing sphere is a teeny percentage of what there is for medicine and health, but the evidence certainly is accumulating rapidly now, especially as more practitioners are being kind of brought into the fold and encouraged to do research projects and things like that. So there's a lot of what I call practice-based evidence being driven as well, which I think is a really good thing.
Well, because there is the more you use evidence in your practice, the more you might also get involved in yourself in developing this evidence. So definitely. So it will explode over time. And as the evidence base explodes, it also requires the users of that evidence to be able to discern good and bad evidence. So that's the whole, so in teaching evidence-based medicine, much of it is about teaching how to decide whether the evidence is any good or bad. So that validity stuff is really important.
I was going to say, one of the things that I've been involved in over the last 10 years has been the kind of creation and perpetuation of evidence warehouses for policymakers and practitioners. So a lot of practitioners and policymakers haven't got the time to read individual studies, especially given the accelerating rate to which they're being published. So finding places that can summarise and synthesise literature for you is incredibly important as a practitioner or professional, because someone else has gone to the trouble of working out what the good and the bad evidence is already, and then packaging it up for you in a way that kind of just tells you the absolute headlines and some more information about where to go if you want to know more. But it gives you that kind of that digest of what you need to know if you need to make a decision based on it. So I think what I would say to the audience, if you're working in the policing space, is look out for those evidence warehouses. There's quite a few popping up all over the world with regards to kind of policing and crime topics, and they're usually very well done. And I think, to what extent do clinicians rely on systematic reviews and things like that?
They are. So not only, I mean, you mentioned systematic reviews, and that's where someone has systematically gone out and identified all the, good evidence, appraised it, and then integrated it and synthesized it. There are several sort of point of care evidence, sort of decision aid systems that are used by a lot of clinicians in New Zealand and around the world. So that is a big thing at the moment. And you were saying about, how long did it take to bring evidence in? It is a moving feast, because first we started off with getting clinicians to learn how to critically appraise individual studies and actually go search for the studies themselves. Then when that evidence base sort of exploded, there's no way an individual clinician would be able to do that. And so we then relied on people who'd done systematic reviews and had to put all of the evidence together, but it still required the individual practitioners to look at the combined studies. They come out with some conclusion, but then you had to integrate that into your decision-making process. And then more recently, some of these new evidence, point-of-care evidence tools have tried to help you make the decision yourself. So they've tried to actually bring the cross together. And I feel that we've gone a little bit far. I think those evidence bases are great, but I do think that individual practitioners need to have a fundamental understanding of how these groups of people who have synthesized these evidence, they need to have an idea of what they've done. And so I feel we've almost gone a little bit far, and we just say, let's just agree, let's just support, agree with what they've decided. Let's just accept that they got it right. So it is. It keeps on moving, this whole field. But at the core of it is making sense of evidence and integrating it into your decision making.
I guess that's been a change in culture, and I know I live with a clinician who uses evidence on a weekly, if not daily basis to enhance your decision making. So that's the really importance of it. I think it's been successful. Is there a New Zealand flavour to EBM here in New Zealand?
Yeah, well, I guess there is a little bit of a evidence flavour, because I understand that, if I remember rightly, you heard about me, was it through your wife?
Yeah.
Because I probably taught her, is that right?
You did, yeah.
Okay. So I introduced the teaching of evidence-based medicine to New Zealand back in the early, I guess it was about early 1990s. Early 1990s I introduced it. And I have always been wanting to make evidence and the appraisal of evidence accessible to everybody. So I've developed a very simple way of teaching evidence-based medicine. And so now every student who's been through the university, every medical student who's been through the University of Auckland since the early 1990s has learnt evidence-based medicine from me. And in fact, the other University of Otago, the people teaching evidence-based medicine there were my students. So they're teaching. So I think if there is a flavour in New Zealand, it may have been influenced by my approach, which was to make it easy, was to make it accessible, not to make it something different from it was adding to your base, your decision-making approach. So I hope I've tried to instill that evidence-based thinking doesn't require you to be a specialist. You don't have to be a specialist epidemiologist, evidence-based medicine guru to actually use evidence. You just need to, like your wife, you need to think about using it every day. And I've tried to make it easy. I've tried to make it accessible and easy and actually normal. Do it when you can. Use it when you can.
Yeah, definitely. Thank you. And And have you seen that change in culture, like since you've introduced it to New Zealand? It evolved?
Oh, yeah, I think now it's become kind of normal. It's just normal. No one, there's no one, I don't think there's anyone disparaging evidence-based medicine anymore.
So anymore implies they once did. So there's always,
absolutely.
When you're introducing anything new, there's always going to be your promoters and your detractors. So did you have some of those detractors in New Zealand?
Yeah. And look, we had them worldwide, and they were no different in New Zealand to elsewhere. I at one stage was working, I spent a year in Oxford at a Centre for Evidence-Based Medicine, and the hospital where our Centre for Evidence-Based Medicine was on the third floor of a hospital called the John Radcliffe Hospital, and used to go up in the lift, and there was a sign to the left saying Centre of Evidence-Based Medicine, and to the right it was Department of Surgery. And so you go up there, and I know that it really pissed off the surgeons every time they went up the lift, and there was like people were saying, that's where they do evidence-based stuff, and then we do surgery, which is not evidence-based. So it did create some heat. It really did, and there were quite a few distractors. And as I said earlier, the real enthusiasts for evidence-based medicine sometimes overdid. It's all about the research evidence. And as I've said many times today, it's not all about the research evidence. It adds value to what you did. It doesn't. Yeah. And so you need to keep on pushing that. You need to keep on pushing that, because you don't want pushback. You don't want pushback. And I think maybe in medicine we don't have that pushback anymore. People are actually looking out and they say, well, look, is there any evidence that can support this decision? Sometimes there isn't. Often there isn't.
Yeah.
And in fact, there's no perfect research evidence for making a decision. We are always having to extrapolate and take out, what we can from the quantitative evidence or the research evidence, and always ask, how do we apply that to my patient? Or in your case, how do we apply this to my particular
crime problem,
exactly,
something like that.
Whatever. It's integrating.
Yes.
Absolutely. So just to come back to the research evidence now, because one of the key debates in evidence-based policing is, and this kind of sounds like it chimes with how evidence-based medicine developed. The original proponents were really pushing randomised control trials, which are fabulous. They are, they are really fabulous research design for controlling for as many things as possible, so that you can have real confidence that what you've done has induced the change. The problem we have in policing is there are often many circumstances that undermine the feasibility of doing a randomised control trial. Some people think they're not very ethical, and that's not just police, but they think communities won't perceive them as ethical to withhold, some sort of police service from half the community or whatever. There's also logistical barriers. There's also, in policing, we also suffer a lot with contamination issues, in the fact that, you can't neatly split across two different groups, a treatment group and a control group. There's all sorts of barriers, and I've got my own opinions on all, where RCTs sit within evidence-based policing, evidence generation. But I just wondered how medicine has addressed, or is moving to address, the kinds of complex scenarios where RCTs just aren't feasible. What else can you do to generate evidence about what works?
Well, it's interesting that everything you've just said is equally applicable in medicine. Even though we have 75 randomized control trials a day published, most of them, most of medicine is still not informed by randomized control trials, because of the reasons that you've raised. The kind of setting and the interventions and everything are just too complex. It's often unethical. As just with you, it's often unethical to do randomized control trials, and the contamination. I mean, as you were saying it, I was thinking this is just.
See, we've thought all along that you've got it all figured out. So this is breaking all of my my cherished beliefs here.
Well, no, but I think I think the way we've attempted to deal with that is that we look at, so in epidemiology, which is the quantitative evidence of medicine, at one end you've got a randomized controlled trial, and then we have these things called cohort studies, which are like a randomized controlled trial, except you don't randomize. So if you were, I mean, for example, if you were interested to get definitive evidence on whether smoking causes lung cancer, and believe it or not, this is back in the 1960s, you couldn't do a randomized controlled trial because, you know, how many people would you say, look, I just want to really find out whether smoking kills people. So would you mind being randomized to smoking versus non-smoking? You know, and of course you can't do that. So the next best thing was to actually ask people, are you a smoker, are you not, and then follow them over a period of time. But that can also take a very long time. That, you know, and the first studies that identified as close to definitively without a randomized trial that smoking caused disease took about 10 years to do. Mm-hmm. And then we have these other studies that we call case control studies, which allow you to do it. It's kind of like a long-term study that you can do. You can truncate it and do it in a year. So we have a wide range of versions. They on one level, they've got the same architecture or same structure as a randomized controlled trial, but they're not randomized. They're kind of attempting to mimic a randomized controlled trial when you can't randomize, and when you haven't got the time or you haven't got the resources. And just more recently, of course, we've now got very large databases. And you have, of course, have equal, you know, you have access to, and the IDI is something that you use. Do you know?
Yes, yeah. My colleagues use that.
Okay, yep. So for those listening who don't know, the IDI stands for Integrated Data Infrastructure. It's a weird name, but there are all of these databases. There's justice, there's education, there's taxation, there's immigration, there's health, there's social services, and all of these databases. You can actually link individual people across all of these databases. It's done in a highly secure environment, so you never actually know who the person is. But you can actually mimic randomized controlled trials or other studies, as you know, in these databases. And so I guess to put it all together, we integrate all of these different data types of research. But then we would also try to integrate it and link it to the the equivalent of forensic. So I think increasingly, even though I'm a epidemiologist and I work with data and I'm particularly working big data, I have colleagues, I work closely with the equivalent of forensic scientists. So I work with people who are working with genetics. I work with people who are looking at pathologists. So all the way down. And I increasingly think of evidence that I use is right across the spectrum from someone like me who kind of uses a telescope down to colleagues at the other end who use a microscope.
And where does qualitative evidence sit in that framework? Because I've argued when I've written in the past about plurality of evidence, and to me that means we need to be integrating quantitative research with qualitative, and they both can be integrated to produce value that's far greater than individual kind of studies. And I know in the healthcare sector you get qualitative evidence on, you know, how patients feel about a certain treatment, how they experience it, whether it integrates into their life in a convenient way, things like that. So how do you weave in qualitative evidence?
Yeah, it's a really good question, and it's we do tend to have quantitative scientists and qualitative scientists, but in my school, in the School of Population Health at the University of Auckland, we work together. We work together. So we have experts in qualitative evidence and experts in quantitative evidence, and we do our best to put it together, because I can count stuff and, you know, as a quantitative scientist. But it's all very well. I can, you know, produce all of these nice sort of risks, event rates, and etc. But it's the point. What does it mean? What does it mean? And what does it mean to people? And you know, with outcomes, you know, we count deaths, we count disease, we count disability, we count all of these things. But what does that mean to people? What's most important?
Yeah.
And so I don't think you can do good evidence-based decision-making without integrating qualitative and quantitative evidence. They are absolutely, they're inextricably linked. And in fact, you know, maybe there's a way that I need to modify my cross, because
you need another.
it's, you know, it is very easy to leave out a lot of the qualitative evidence. And in fact, you know, actually the integration, quite a lot of that qualitative evidence relates to the integration of the, you know, quantitative evidence with values. Well, how do you learn about values and preferences? That, you know, that values and preferences quadrant has a huge qualitative component. And indeed, when we talk about the patient's clinical circumstances, we're not just talking about their physical health, we're also talking about their mental health and their social situation. And there's, you do need good qualitative evidence to actually tease a lot of those out. So yeah, I think I could do a better job at being explicit about that qualitative evidence, but it's absolutely essential.
I think that lived experience, you know, of people is really important, particularly in crime, their feelings of safety and things like that. So yeah. Mixed methods. We talk about mixed methods, and we have some mixed methods courses, but you know, there's no doubt that people tend to, you know, certainly scientists tend to be either in one camp or the other.
We're working to change that, though. It'll be another 20-year plan.
I think we need integrators. We need both. We need people with real expertise in each area, but we do need integrators. We need the mixed methods, you know, scientists as well. Or actually, often they're practitioners. You know, some of the best people to do that integration is to have, you know, on one arm they're linking with a quantitative scientist, on the other they're linking with a qualitative, and often it's those practitioners who may be the best people to do the integration.
Oh, wonderful. I've just got one last question, because I'd like to leave some time for the audience to maybe ask you some questions. But so again, I think this might be another misconception from evidence-based policing scholars, but we tend to assume that medicine has got it all figured out, that you only ever run a randomized control trial when you've really teased out the mechanism in diagnostic or prognostic kind of research studies. And so but then COVID was a perfect example of when you didn't know what the mechanisms were, but you had to find some solutions. So how do you go about choosing interventions to test when you're not really confident what the mechanism is that's causing a particular health problem? How do you select interventions to test?
Yeah, so COVID's the perfect example. There was just so much uncertainty. But in my work, uncertainty is the norm. Uncertainty is the norm, and I think, you know, I think you're right that it is a misconception that medicine's got it all sorted out. Yeah. So how do you actually come to decisions about what to test, and actually not just about research, but how do you make decisions like about lockdowns, about, you know, all of those things, about regulations about if you're not vaccinated, you don't get to come to work, and all those things. How do you make those decisions? Well, look, this is where you have to integrate everything. You really have to look, well, certainly in the evidence, you have to look way beyond the quantitative evidence that I work with. You need to integrate the qualitative evidence about what does it mean to people, what are their priorities, and you also, I work very closely with molecular sort of scientists, genetic scientists, clinical scientists, and with, population health, public health epidemiologists. During COVID, I was talking on a regular basis with people right across the scientific spectrum, and we had to try to work out what was the best thing to do in these very uncertain circumstances. But it is the norm. Uncertainty is the norm. It is not the exception in every field. And again, that's where, the different evidence bases help make you a little bit more certain, help push you in a different direction. But sometimes during COVID, it was the molecular scientists who ruled the day. Other times it was the epidemiologists that ruled the day. It varied as the epidemic progressed. Different types of evidence came to the fore. I don't know what else to say, but I'm a great believer in integrating across and acknowledging or multiple different types of evidence, including, the evidence that comes from experience. That is that's an evidential. It might not be as systematic as the evidence that I might like to use, but it is evidence. It is evidence. Yeah. So be open to all sorts of evidence, but be more explicit. Be more explicit. And I think, if anything, probably the key, the key development of evidence-based medicine has been making decision-making more transparent.
And that's, I was going to say, that's a wonderful place to, I think, just end it for now, because I'm just wondering if there will be any questions. But you're singing from the same song sheet as I've been singing for many years, so we couldn't have planned it better, Rod. So there you go. But we've got some questions. April, would you like to manage the questions?
Yeah, for sure. Thank you so much. That was really interesting, and it's quite validating as someone who's working more in the evidence for crime area to hear that many of the challenges we're experiencing are challenges that are experienced in other fields too, and it's good to see ways of overcoming that. So we've actually had quite an active chat, which is awesome. We have a question from Dr. Lars Braben, who said, Dr. John Snow mapped cholera in 1854, which informed the decision to close a water pump. Surely evidence-based practices in medicine have been around for a long time. Is evidence-based medicine just a new label?
Right. Look, John Snow is famous in epidemiology. The other famous physician, and his name has just eluded me, but you've heard of limeys, how British sailors back in the 1700s. His name is just, but anyway, and scurvy, was so common in the Royal Navy. And then a physician decided to actually give sailors limes, and they used to take limes on board. And he basically did a randomized control trial, and I can't remember when that was. It was 17 or 18. Anyway, well over 100 years ago. And so the first randomized control trials were done way back. It did take about 50 or 60 years for his randomized trial to be put into practice, but that's when British sailors got called limeys because they didn't have scurvy and they didn't like slime. Anyway, so but I think the key change was that epidemic of evidence that I talked about. That, as I said, when I went through medical school, John Snow was in my textbooks and everything, so I did know about that. But that kind of evidence was only trickling in. It was the explosion of evidence in the 1980s, 90s, and since then, and it just keeps on growing, that required us to do things more systematically, more explicitly, more transparently. Yeah. So that's the big difference. There was so much more. There's always been some of this evidence around, but not very much. It's that explosion of evidence.
Awesome. Thank you. We also have kind of a few questions folded together from Dr. Armin Tamatea, so I'll do my best at reading it out and you can pick which bits to attack first. So Armin says, thanks for an interesting kōrero. I like the diagram, but what's missing for me is theory guided. So how evidence is or can be interpreted and being open to alternative readings. As well as that, culturally informed. So what is acceptable to end users, which is not quite the same as values and preferences and speaks to different lived realities. And thirdly, ethical practice. So safety first always. And then just linked with that, also the term evidence-based can be loaded and prioritizes certain research traditions and epistemologies, which you did get to towards the end of the discussion. And as such, it can be code for privileging authority. And one last thought is that psychologists have been doing this since the 1940s as well. So interested to hear your thoughts.
Yeah, look, I support everything that's said there. I can't fault it. You know, evidence-based medicine, we didn't create it. And you're right. I mean, psychologists were doing systematic reviews and meta-analyses way before we got into it in medicine. Medicine, we tend to be quite conservative and we get to things quite late. So I totally acknowledge that. And ethical practice, well, yeah. And again, you know, the way I think of evidence-based medicine, as I've said a number of times during this, is that it's not new. It's adding new components to our decision making, so you know, we've always had a focus on ethical practice. I mean, that's key to medicine. The Hippocratic Oath, first do no harm. So it doesn't replace the bringing in this external research evidence doesn't replace anything that was there before. So I think it's there to add. And I do like, I mean, I think the comment about culturally informed decision making is really important. And I do agree that values and preferences don't necessarily cover that. In my more expansive version of the cross, when I under values and preferences, I don't just cover the values and preferences of an individual patient or an individual practitioner. It's also about the values and preferences of groups and populations, of ethnic groups, of communities. So I apologize. I mean, that it's probably going to fit sort of in that quadrant, but it needs to be expanded. It needs to be expanded. And theory guided, again, you know, evidence, I'm very open to, I mean, the kind of evidence that I work in is very empirical, but it's often theory based. I mean, otherwise we'd be working in a vacuum. So I think theory guided research is like really important. And so that top quadrant of evidence is a very big quadrant, and it's got to cover far more than in your field, forensic and research evidence. It's much broader. It's much broader. So I can only say I completely agree with everything that was said. But you know, I come back to the transparency and being explicit. I think that's one thing, that telling people that we need to practice in an evidence-based way. Okay, tell me about how you make your decisions. Tell me about you know, these cultural preferences and culturally informed, and tell me where it's not being culturally informed so that we can do it better.
Yeah. Okay, so there's one final comment also from Dr. Armin Tamatea, which came through as near the end of the discussion, as you were talking about the need for mixed methods and the distinction between quantitative and qualitative research. And Armin said, is qualitative and quantitative really where the lines are drawn, or is it more about the unit of analysis? So, for instance, most of this conversation has concerned the individual as the unit of analysis, when for many, issues concerned with health and crime are at the level of the community. So that's sick society model.
Yeah, well, I mean, that's music to my ears, because I work at every level as an epidemiologist. I mean, I work, I trained in clinical medicine, so with individuals, then I retrained in public health epidemiology. I subsequently have worked in clinical epidemiology, but I work at all those levels. And you have to work at all. I think it's a really, really good point, is that the unit of analysis varies depending on your question. But I think those comments are very apt. In our research, I work in a big health data research group, and we, our co-directors, we have 2 Māori co-directors and 2 non-Māori co-directors. We also have a Māori-led data sovereignty group. We have 12 people, 6 Māori, 6 non-Māori, and everything that goes through our research group, from an idea for a research project to the initial results, right through to the publications that we want to, well, the papers we want to publish, everything goes through this 12-person, 6 Māori, 6 non-Māori data sovereignty group. We have ethicists, we have Pacific people, we have South. We're really focused. I mean, our focus is equity. Our focus is equity, which is as much, if not more, at a group and community level than it is an individual level. Yeah. So I totally support all those comments. Yeah.
Awesome. So we have a few people in the chat just saying thanks so much. Thanks for the fabulous talk. I know myself, I've enjoyed this a lot, and I've learned a lot from listening to you all. So I think I'm going to close this meeting now. Thanks so much again. Thanks to everyone who attended. And I really hope you got something out of this. So bye. Have a good day.
Thank you.
Thank you so much, Rod. Thanks, Lisa. Thanks, Brian.
Thanks, April.